on our website and also on YouTube channels shown on the screen. Live streaming is also available right now on our YouTube channel, Irish Global Health Network. If you have any questions during the webinar, please use the question and answer feature in the bottom of the screen. And for now, I will leave you with my co-host, Nadine Ferris-France, the Executive Director of Irish Global Health Network. Nadine?
Thank you, Hala. So welcome everybody to our, as I said, the 10th webinar. It's amazing how quickly the week comes around and how many, suddenly we've had 10 webinars. And today, as Hala said, we're particularly excited to be co-hosting this with the Society of Occupational Medicine and also to be focusing on healthcare workers, really something, something that we're very privileged to be able to do. So excited to have speakers, amazing speakers with us today. We have Dr. Ivan Ivanov. You're so welcome, Ivan, team leader for the Global Occupational and Workplace Health team in WHO Geneva, and he's also serving as part of the COVID response team with WHO's Global Emergency Programme. So we're grateful you could take some time out to join us today, Ivan. We have Dr. Will Ponsonby, who is the president of the Society of Occupational Medicine. He's a senior lecturer in occupational medicine in the MSc on occupational medicine at the University of Manchester. Delighted to have Will with us today. We have Professor Pierluigi Cocco. He is in Italy. He's a professor of occupational medicine at the University of Cagliari with a long-standing collaboration. I hope I said that even slightly right.
No.
I need to work on my Italian for
it's
sure.
Too difficult for you. Okay.
Cagliari, maybe that's better. And the university has a long-standing collaboration with the Occupational and Environmental Epidemiological Branch of the US National Cancer Institute. Delighted to be welcoming Joy Mugambi. She is sitting in Kenya today. She's a general practitioner in Nairobi. She has done a lot of work with WHO on occupational health of health workers, and she's also the Secretary General of the World Health Organization for Family Physicians in the Africa region. So welcome to Ireland, Joy. And lastly, not leastly, we have, of course, our webinar anchor, Professor Rory Brua, who's the former head of epidemiology and public health in the Royal College of Surgeons in Ireland. Today, towards the end of the webinar, we're also going to show just a very, very short clip from a new video series that's been launched this week between the Gori in Wexford and the Gori GP practice and Malawi, a really interesting video for healthcare workers. So, Rory, if I can hand over to you, if you could just kick us off, we'd love to hear just the state of play as always. Thank you.
Okay, not sure if this is going to come in. You can just let me know. So I'll speak through it in the hope that the share screen will come up. Is it coming up?
This, that's good.
Great, so let's just try and get into slideshow. So the first half of this just short introduction is going to just look at a global overview of the pandemic and then some transition slides into some slides on impacts on health workers. Fortunately, we'll have much better inputs from the panel. So these next three slides are from the worldometer. As you know, I'm a fan of it. Here's and what I've done here is I've just pulled out what I think is most useful in the worldometer. So most of these dashboards show total cases and total deaths. It provides three other useful indicators, which is cases per million population, deaths per million population, and tests per million population. The problem with any dashboard like this is if a country isn't testing, then we don't really have any great insights, and usually there's a lot of underreporting that goes on. So we have over almost 5 million cases there, 334,000 deaths. And as we know, the US is way ahead in terms of cases and way ahead also in terms of deaths. Its testing is improving, its level of testing, and Russia's level of testing has improved a lot, though we're not quite sure what's happening because they're reporting an inconceivably low number of deaths per million population. And Brazil, as we know, following in the media lately, is rapidly, it's on its way to second in the world in terms of the impact of its pandemic. So I've just kept in, on the left there are the numbers of cases, that's how the countries are ranked. I actually left Italy out. Italy is quite similar to Spain. And I kept in UK, Germany and China. So the most notable thing here is, as we will see, the countries that are performing really badly, as we discussed last week, are ones where there's very poor leadership. Of those countries there, Germany is probably performing the best, but China had a remarkably successful virtual suppression, even to the point that maybe it is underreported its deaths. But it's the second and third slides now, if I can get into them, that are more interesting. And the first thing I would point out is you've got Sweden at the top there and Norway at the bottom, two Scandinavian countries. And I'm going to say a little bit more about Sweden later. But what stands out there is that Sweden is the one country, as many of you will know, that have gone for this herd immunity approach and a very light sort of distancing, no mandatory closures. And they've had twice as many cases as Norway, and similarly for Denmark and Finland. They tested half the number of people per 1 million population, but their deaths are almost 10 times as high as in Norway, and is similar in Denmark and Finland. And I'll say a bit more about that later. But in here, we have some of the really good performers internationally, Singapore and South Korea. And really the marker of success is your death rate and your death per million population. And in the case of some of these, like Korea hasn't done a lot of testing. And I think we really do need to keep going back to Korea, Singapore, Hong Kong, Taiwan, and China to see what did they do right, because we can continue to learn lessons from them. Ireland is doing really ramping up the testing, but we're not great on deaths per population. And now we see South Africa coming in there. The well-performing countries in Europe are Portugal, Czechia, Czech Republic, and then when we see here, Greece, Iceland, Slovakia. They're the sort of smaller countries of Central Europe, Southern Europe. We know Australia, well, we know New Zealand because we're so impressed by our Prime Minister. But actually, if you look at the indicators for Australia, they're very, very similar to New Zealand. And perhaps it's easier to isolate yourself when you're down in the Antipodes. But again, look at these death rates, incredibly low in Hong Kong and Taiwan, which is where we need to be looking for our lessons. So what do we learn from, and this is a very sort of a crude categorization. We've got the early controllers in Asia, very quick, decisive responses, and they learned from SARS and MERS. That's what a lot of the literature says. Variable in terms of tracing, but really in terms of testing, but really good on tracing and tracking cases. And I'm going to mention that in a minute. One of the controversial areas we have to look at is how do we balance the population interest, the public health, versus the importance of privacy and GDPR that we put on privacy in Europe, because the tracking of the cases is the difference. We've got the early controllers I mentioned already in the West, quick and decisive responses, quiet leadership, usually high levels of testing. And then we got the late controllers in Europe, the ones that were really caught unawares. I mean, we were able to learn from the misfortune of Italy. In a way, Italy, you could say, should have the less sort of blame attached to it because it was the first in Europe. Spain, okay, followed very closely on Italy, and so did France. UK eventually has joined the late controllers and has left this group, the failed responders, the anti-scientific leadership characterized by denial, blaming others, blame China. And the latest thing the Republicans do in the US is they blame the dead. They blame those Americans who were weak and who died. In other words, lower social class, minority ethnic groups, huge underreporting of cases and deaths still going on. And then the delayed epidemic in Africa that we've talked about before. I just thought I'd put in a couple of issues here. There's a link to two interesting Guardian articles. People are talking about, is there going to be a second wave? And there's a belief that there won't be, and others are saying a second wave is coming. It's more likely, I think, to be eruptions that will need to be stamped out. This article is by a veterinary epidemiologist, so it's worth a read. The other one that came out this week, yesterday, was Stockholm, Sweden, that had put its faith in this herd immunity approach. We had Johan Giesecke, eminent epidemiologist on News Talk the beginning of the week, saying we were doing it all wrong. Well, they are not achieving their herd immunity. Real cold water being poured on this theory. And this is as I transition into the theme today. Why do we invest huge resources, and why do we shut down our economies for weeks and months? And I'm prepared with, so if and when I'm called upon again and asked that question, it's not just about protecting the elderly and the vulnerable. It's about protecting our health workers, because our health workers are not going to just let people die. And as we will see, there's been a huge impact in Ireland, not so much in mortality, more in incidence. There was a much bigger mortality in Italy, and we'll be hearing from our panel about that now. But quite variable levels of mortality. There's a paper that I didn't fully cite it at the bottom, but our panel member professor will know about it if he wasn't even an author of it. But much lower levels incidence in Italy, and it was high levels in nurses, midwives, and others. Otherwise, it was doctors, but quite high levels of deaths in Italy as well. And one of the things that Italy did, which I think we did to a certain extent, was to recruit retired doctors, retired GPs, and PPE shortages. That's in the article there. But we by far have the highest incidence in Europe of infections among healthcare workers. We'll see that in a minute. And I just want to give a shout out to Michael Kelly's excellent article on gender and COVID. And as he points out, 75% of confirmed cases in health workers are among women. So David Weekling prepared these slides here on healthcare workers in Ireland. I'm really disappointed to see that having stabilized around 25-26%, the latest data is suggesting could be up around 30% of all infections. Younger, less likely to be hospitalized, less likely to die in Ireland. As we saw on the previous screen, the doctors actually are more likely to die proportionate to the numbers of their cases. And that's probably because of the aerosol procedures they do. But we're screening healthcare workers better now, which is the right approach. And therefore, we are probably detecting more cases and have a lower case fatality rate. Some of the big issues that will come out now will be around stress. And in Ireland, we may well be seeing transmission in the community to healthcare workers. That was one of the hypotheses that came out 4 to 6 weeks ago, that a lot of nurses live together, and to an extent doctors do as well. So here's just one article. I'm not going to dwell on it. We need to get onto the panel now. It's based on a literature review, and it just has identified some of the issues that we need to consider in low and middle income countries, because if there's a priority in terms of the health system, it's protecting the health workers. So thank you. I hope that wasn't too long, Nadine. And over to a much better, more knowledgeable panel than I am on these issues.
Rory, thank you. That was really, really useful and quite surprising, actually, I have to say, just looking at that presented, the way you've presented it. So I think if we can, I'll start by coming over to you, Dr. Ivanov in Geneva, and just asking you, tell us a little bit, can you just maybe tell us about the WHO occupational health strategy for healthcare workers during the COVID-19 pandemic? And we do have, if you want to look at your slides, we have some slides if you'd like us to show them, or otherwise welcome just to speak freely.
No. I will go today without slides.
Great.
It is just the opportunity of being with you all in Zoom and talking to you all. You already know that for WHO, the health workers are a major concern. And we're concerned not only about the so-called healthcare professionals, doctors, nurses, midwives, we're concerned about all workers in the health sector, including the cleaners, the drivers, the community health workers, the pharmacists, those who do disinfection. And we did a lot of studies actually to understand what is driving the infections of COVID-19 among health workers. Currently, we have more than 45, maybe this week already, about 50,000 health workers who are already infected with COVID-19. The evidence shows that there are a number of occupational risk factors for the infections among health workers, which include a lot of long contact with COVID-19 patients working in such wards. Of course, the lack of sometimes insufficient personal protective equipment or insufficient compliance with requirements for personal protective equipment. A very big driver is the insufficient hand hygiene. Hand hygiene is very important and has shown a lot of impact on health workers. But also the studies show that many health workers, actually maybe the majority of health workers, they get infected in the community. They get infected in their family, they get infected in the community, not at the workplaces. Even some argue that the workplace is actually safer than the community when there is a widespread community transmission. So also the infections among health workers, those that are acquired at the workplace and that are investigated, are also related to long working hours, related to poor working conditions, crowded workplaces, sometimes socializing among health workers in the rest places without really observing physical distancing in such places. So workplaces in the health sector can also contribute to the infections. But in addition to that, this whole crisis in the health sector and in the societies has amplified other occupational risks, quite well-known occupational risks for health workers, such as violence, stigma, discrimination. We unfortunately, despite the many efforts of social mobilization around the world to applaud health workers as heroes, we see drastic cases of violence against health workers, throwing bleach in their faces, spitting in their faces, physical violence, and unfortunately, health workers coming from migrant health workers or from ethnic minorities, they tend to be quite more targeted to violence. We also still see dramatic situations of social stigma among health workers, where they have been expelled from their homes, the community have beaten them, and sometimes they do provoke actually that stigma by wearing uniforms and gowns, going out in the community in gowns, but it is not tolerable. Therefore, WHO has called publicly on the 28th of April, we have issued a call for zero tolerance to violence, harassment, discrimination, and stigma against health workers. And countries have already acted. India has issued a special law. China also had already a special law for violence against health workers. Unfortunately, Europe is behind in many countries. In my own country, Bulgaria, there is still not a law to criminalize violence against health workers. We are also concerned with the very high workload and already several months workload, long working hours, shifts, lack of rest, fatigue, and the tremendous impact of all these crises on the mental health of health workers, where we see already cases of suicide among emergency health workers in Italy, now in the United States, and this is an enormous concern. Also, there are a lot of that all attention to COVID-19 has a little bit downplayed the safeguards against other occupational risks. For example, back injury is a major occupational risk among health workers, and handling of patients, of COVID-19 patients, requires quite a lot of lifting, moving, shifting, changing positions. that are also strain for health workers. And we are concerned also about the impact of prolonged work in PPE on health. There are skin damage, there is mucous damage, there is heat stress arising from long working with PPE. What all this crisis has shown to us is that basically we do not have sufficient level of protection of health and safety of health workers, let alone their rights also, let alone their rights to refuse to work when they are not safe, let alone their rights to have safe and healthy working conditions, to have occupational health services. What happens in other high-risk sectors, and the health sector is among the 4 highest risk sectors in the world, is that in the mines, there are good occupational health services, there are special laws, there are special regulations, but when it comes to the health sector, we rely on just general occupational health and safety, and there is no special attention to the health sector. That's why on the 28th of April, our Director General, Dr. Tedros, he called upon countries to develop special programs for occupational health of health workers to make sure that they have the right to decent, healthy, and safe working conditions. Over.
Yeah, thank you, Dr. Ivanov. That's a really, you've painted a really comprehensive picture of many of the issues for healthcare workers. I wonder if you could say something just a little bit on, you know, some of the practical considerations for protection of healthcare workers, particularly in low resource settings, in terms of what do the WHO guidelines say at the moment on that?
Well, the WHO guidelines, they are for all kinds of countries and for all kinds of settings. We do not have specific settings, specific guidance for low-income settings. We do have also some recommendations, particularly understanding that there is a shortage of personal protective equipment and how to have a rational use of personal protective equipment. But with regards to all countries, and particularly those countries where the general occupational safety and health laws do not apply to the health services, this is a big concern. And in these countries, we have worked with them. Example is Kenya, to develop a national program on occupational safety and health of health workers, so that they enjoy also some form of protection. In every health facility, there should be someone who is responsible for health and safety, to make sure that there are gloves, to make sure that there are masks, to make sure that disinfectant, that workers know how to lift weights, that to provide first psychological aid, to make sure that things happen, that is not only left to infection control, but there are also other aspects, to make sure that there is triage, to make sure that they can wash their hands, that they have access to safe water and sanitation also, that is very important, to personal hygiene, that they do not take their clothes at home to wash them at home. And this is very important, to not take your clothes at home. So these are very basic measures. And of course, the most important is to apply the standard precautions when dealing with our patients to prevent health workers from infections, but also the protection against violence, and that does not require a lot of resources. And that happens in all settings. If the violence is in the community, it will come to the health facilities as well.
Dr. Ivanov, let's, if we can, I'm going to leave it there and ask people who are watching if they have questions for Dr. Ivanov, just to put them in the question and answers, and we'll do our best to get them to him or to answer them, to have them answered for you in the chat box. And if I can, I'm going to move along to our next speaker and then hopefully come circling back around. So if I can move to you, Dr. Ponsonby, you know, we've heard quite a bit about the hierarchy of control as a risk prevention tool. Can you just share that with us from your expertise on occupational health?
Certainly. I think that when we hear about the controls for healthcare workers, we hear about PPE, and people are very concentrate on the PPE and the provision of PPE and the adequacy of it. But actually, PPE is only one control, and there is and it's only one barrier. And PPE, if you have the correct PPE, you have the correct training, and it's used well, can be a good control, but all controls fail at times. And therefore, it's much safer to have multiple barriers. And if you have all of the other correct controls in place, the need for PPE is reduced. So the hierarchy of controls, first of all, you should try and eliminate the hazard. In the terms of coronavirus, that could mean good testing so that you can identify those who have the virus and they can be cohorted, and then you can have areas of the hospital which are virus free, and so the people working in those areas will obviously have less exposure. The second level is substitution. Well, it's difficult to substitute the virus for something else. It's something that we do in industry, where we look to find a different way of doing things. And then we have engineering controls. So in hospitals, we might look at having good ventilation, and we might look at physical barriers that we can put in place between the healthcare workers and the patients, screens, or even put the patients into cabinets that, a bit like a fume cupboard, that healthcare workers can reach into and be outside and protect themselves. The next level is administration controls, and one example of that would be fitness for work. This is testing the healthcare workers to identify any who are vulnerable and removing those from the high-risk settings. Also, again, testing and cohorting the workers may be an example of that, and also very good sanitation and hygiene, and I think fatigue management. And then PPE is the lowest control, and that should come last. And as I say, if we have everything else in place, then the importance of PPE is reduced, and people should be well protected. Over.
Yeah. And I wonder if you could, you know, you're talking about the hierarchy of control. What kind of recommendations would you have for low resource settings, for instance? What should people be really thinking about in terms of protecting themselves? What equipment? How should they do it?
I think first of all is, if they do have access to testing, is to try and cohort patients. So try and have the areas where the patients who are infected are treated, and have a separate area for non-infected virus patients for all of the other illnesses which are still presenting to the hospital. Secondly, I think look at what engineering controls you can put in place in terms of barriers, etc. Ventilation, we know that increasing ventilation can reduce the viral load, so look at options for that. And then the administrative controls, I think, again, looking at fitness for work and identifying the most vulnerable members of healthcare staff, those who have comorbidities, those who are in the older age categories, and perhaps removing those from the areas where they have more exposure to patients. And you also need to identify the highest risk areas of the hospital, those with aerosol generating procedures such as the intensive care unit, the bronchoscopy suites, the endoscopy suites. And it may be that you know, during this time you have to minimize some of the procedures that are done there, and they're only done for emergencies. And then when the procedures are done, the people carrying them out have the highest level of protection.
And what about you know, occupational health services? Any recommendations or ideas on? I just see a question has just come in there from Sarah, just in terms of how to strengthen occupational health services, particularly in low resource areas.
I think that's a real challenge, and I think, you know, what we need to do is, I think a lot of work is being you know, developed in Europe in terms of identifying, you know, vulnerable healthcare workers, and that's something that we can share, although the different ethnic mixes in different countries will cause those to vary. I think that but there are some common themes in terms of the comorbidities of diabetes, heart disease, and age as well, that make people more susceptible. So I think occupational health has a real kind of role in doing the personal risk assessments for the individual to say that they're in a more vulnerable group or not. And they can then advise the line manager, and the line manager can then do a workplace risk assessment to decide if that person is fit to work in that area or needs to be redeployed into a different area of the hospital, which perhaps isn't patient facing. I think also, and some of the other issues that Ivan was talking around fatigue management, I think mental health is extremely important at the moment. Supporting workers, supporting managers, and telling them what they need to do to provide good support for workers is also a very important role that occupational health has to play at this part. We're also working with colleagues in other specialties such as occupational hygiene, so we can get really the best information and advice about how we use PPE, making sure that people are properly trained to use the equipment that they have, that they get the fit testing that they need for the respiratory protective equipment. So even in a resource-constrained environment, we need to make the best of the equipment we have, make sure it goes to the people at highest risk and that they're well trained to use it.
And then just maybe as a last question, we heard a little bit from Rory about Ireland. We're going to hear a little bit more from Italy and from Kenya. But what about the UK, where you're sitting at the moment? What has been the UK health workers' experience during this pandemic, particularly from an occupational health point of view?
I think like some places, not all places, we found ourselves not very well prepared for this. And there is a theory that in the UK, we were prepared for an influenza pandemic, not a coronavirus pandemic, whereas I think the Asian countries perhaps were more prepared for that because of their experience with SARS. I think that in the initial phases of the pandemic, we were scrabbling to put in place the control mechanisms. We didn't have enough PPE for healthcare workers. We didn't have the correct PPE, and the distribution wasn't adequate either. I think also there was a problem with identifying the challenges with the social care sector in the United Kingdom. These are the elderly people in care homes, not in the hospitals. And the fact that we didn't have enough testing in the first few months or so of the pandemic to identify those who actually had the virus, both patients and staff, and that resulted in people who were infected being moved into into care homes and then infecting other residents there. And that's not been unique to the United Kingdom. I think a number of European countries have experienced that. I think we have had several hundred fatalities in healthcare workers, unfortunately, in the United Kingdom. One of our experiences is that the Black, Asian and ethnic minority workers have been disproportionately represented in that group. And there are investigations underway as to why that has happened, and you know, what can be done to prevent that. But our experience has been as well that although there have been the numbers of infections within healthcare workers, the majority of them are probably community acquired. Many of them, I think, are acquired between healthcare workers, passing one healthcare worker infecting another healthcare worker. And although they might be very disciplined when they're actually in the ITU or on the ward serving the patients, they're less disciplined when they go to the breakout rooms afterwards. And these may be kind of areas where infections occurred. And one of the things that we've been trying to do as a society is move the debate away from just PPE to actually implementation of the complete hierarchy. And that gives people more protection, as I've said before, and actually means that if for any reason their PPE isn't working, then hopefully the other barriers will keep them safe and give them confidence.
Yeah. Thank you so much, Will. I think we're going to put a link in the chat there to the hierarchy of control. And if I can, I'm going to move just from the UK over to Italy, to Professor Coco. And obviously Italy has been on everybody's, in our hearts, in our minds, in terms of solidarity, in terms of how you've been coping and responding, and also just so keen to learn from the lessons of Italy. So I wonder, Professor Coco, if I can ask you, you know, we talked about mental health concerns. That's come up a few times already on the panel. What are the mental health concerns in Italian health workers, and what have they been during the pandemic? And considering that the disease has shown it's been a wide variation from northern to southern Italy, have the healthcare have the issues, mental health issues, differed among health workers in those regions?
I think that actually lack of preparedness was something that was common across a number of different countries all over the world. And this was one of the problems that led to a series of conditions leading to different attitudes in healthcare workers. For some, it was kind of accepting their own role and to put themselves in the front line against the disease and sacrifice themselves, working long hours, and more or less, but the problems were more or less the same, that Dr. Ponsonby described about the UK situation. So at the end, one of the problem in facing COVID was the high mortality rate, particularly in the elderly, and the insufficient support from the authorities, and of course the limited availability of personal protective equipment, particularly in the first weeks of the epidemics. So at the end, burnout was really a problem for them, and this was particularly clear in the northern Italian regions, where the disease eats so strongly. And on the other hand, there was another attitude which was based basically on fear, and then the anxiety in dealing with the disease, which is kind of potentially deadly disease. And this problem actually was spread all over the health workers, but was more clear, I would say clearer, and in the regions where the incidence actually was lower. For instance, I've been lucky enough to live in an island and to have to deal with a very limited problem compared to the rest of Italy. But fear was really an issue. And we had to deal with it. Anxiety and stress was particularly strong. After all, this was the problem, one of the main problems we had to deal with. So that was the difference between the low incidence versus the high incidence areas. But both problems actually were occurring in these all over the Italy, all over the country.
And Professor Coco, when you're talking about burnout and stress, and how have you supported healthcare workers as they have been dealing with burnout, with depression or other health conditions? What have you done that we could learn from, and even are still doing?
Well, at the beginning, actually not really at the beginning, but at the beginning of March, there was an agreement between the Italian government, the unions, and employer organizations, allowing furlough for people with, let's say, vulnerable conditions, and to prescribe them self-isolation, and using a kind of special codes to allow them to stay in a sick leave as a justification for for the absence. And this was simply for precautionary reasons. And then each occupational physician had to deal with these vulnerable conditions. For instance, there were instances of direct or indirect immune system deficiency. And so the workers with these conditions had to be alerted and allowed them to stay at home, to furlough them, and with this kind of precautionary sick leave, let's call it this way. And then for the rest of the workers, they have been asked to contact the occupational physician and to examine their cases one by one. Of course, this meant a massive amount of work to discriminate the need to balance between protecting these workers and the functioning of the hospital. So on the other hand, vulnerable conditions in the agreement between the unions, the employer organizations, and the government were indicated only in relation to physical ailments. Okay, not really, for instance, mental health issues were not considered. And this was a problem. I mean, there are not real statistics about that, because we would have to wait perhaps next year to have some numbers about that. But there were instances of suicide among healthcare workers, doctors and nurses. And we don't know whether this really was related to the stress and to the anxiety, and the burnout followed that followed the epidemics, or were something that would have happened anyway. They had been described just because they happened in the wild. But I think that some statistics will be interesting to provide some information about that in the near future.
Yeah, and I'm just wondering, what about it's a question I think on everybody's mind quite a lot, is what are some of the Italian strategies that you've had to cope with the increased pressure on the health system? What lessons have you learned, and particularly in relation to healthcare workers and support?
Well, first of all, there were kind of economical constraints in hiring healthcare workers in the past. And one of the first things that have been decided by the government was to kind of relaxation of these constraints. And so there have been a number of people that have been called back from retirement, for instance, and this has been already said before, and also a number of new people that are being hired because to face the needs to allow healthcare workers to have more reasonable shifts, for instance, some attempts are really being, I would say, need to be evaluated critically. For instance, the idea of building new hospitals. A new hospital has been created in 2 weeks in Milan, and it was planned to accept 600 COVID patients, but at the end, only 24 were admitted there, and now it's completely empty. And €2 million have been spent to create from nothing this new hospital. It was a kind of attempt of replicating the Wuhan hospital, but really it was kind of failure because it was a decision made on the pressure of the rising wave of the epidemics. Then by the end, the 2 weeks that they employed to build them, the curve was decreasing. So there was not that much pressure any longer. So there was not much need of it. So this is an example of lack of preparedness, really, because another choice instead, another example, this time a good example, might come from the Cotugno Hospital in Milan. This was a kind of specialized hospital for transmissible diseases. And it has always maintained its role. Instead, there were the so-called sanatoria. The hospitals to treat tuberculosis in the past, where people was admitted at long-term admission there, and they were just shut down or transformed in general hospital. And at the end, general hospitals have been the place where the disease has spread more quickly and more heavily. And possibly a stronger net of support at the, domestic support. On the territorial health would work much better than the hospitals to treat these diseases, because otherwise it might be just a way of spreading it instead of curing it.
Well, thank you, Professor Coco. Lots of food for thought there, and thank you for sharing those lessons. I think in the interest of time, I'm going to move from Italy to Kenya to Dr. Mugambi, if I can. And Joy, you're at the moment, you're on the front line in Kenya, responding daily at the moment to the pandemic. Tell us a little bit about your experience in relation to protection of healthcare workers. What's happening?
Thank you very much, Nadine. For Kenya, I truly appreciate the fact that at the very beginning, our president began with putting an order for all those above 50, those diabetics, hypertensives, and electives to be held so that we eliminate the risk for those groups. Then when it came to the facilities, we also limited the non-essential services. And we appreciate the fact that also continuously, as the numbers have been rising, we've seen regional containment of areas where there is a high burden of COVID infection. Though we, as a facility, will share something that we have done. When we started off, there was the whole challenge of PPE, just as we've heard from all other regions. We didn't know where to get. Flights had been stopped. Most of our PPEs are imported, but we do appreciate that the industries that deal with textiles moved with speed, started production of masks and hazmat suits. And currently we can say in terms of PPE, the stock levels are not as bad as we were at the very beginning. To share out, I'll share what we currently have done as a facility. As I load my PowerPoint slide, yes, I like the fact that we've been told the hierarchy of protection is not about what you wear. It's about elimination, substitution, engineering, controls, and we did take that into consideration, though we did put a number of modifications. At the facility, we were all dressed up in our hazmat suits that had been supplied in preparation for eventualities of Ebola, because we are on the highway between Kenya and Uganda. And remember, Ebola had struck us at one point. Still on the same, we moved out from wearing so much hazmat suits and built this cabin, borrowing the model of Korea, where it's a glass cabin. Health workers can easily go at the back, inside the glass cabin, using the gloves that are extending out, take a sample or examine a patient. This is not a patient. This was just a demo to our administrative staff. And once they have done the testing, it's easy for even the client to help you seal it, disinfect it at the outside there, and then later come to collect the samples. We've already modified this a bit with a locker area here where samples can be easily placed. This is one of the other controls that we put in place. We segregate coffers to one end and ensure that they are not mixing with the others, and review them in this room at the corner there and test them out here. Any health worker can do testing. We do not have a special team that's to do testing because COVID is not going today. It will be with us for a long time. So everyone had to be trained and be able to understand how to do these procedures. In an event, we also are short of staffing. The other thing we did, we've done a lot of community testing. We've also had postmortem testing out in the community. This is a community control measure that we were doing. We didn't want, there were travelers, there were people who had come from outside the country, but we could not leave them to travel all the way to the facilities and put others at risk in their transport systems. So we have gone into the community also doing testing. And yes, we do have the full PPE, but we are also encouraging the use of the cabins. And if we could get more cabins into the community, that would help. But for those we have to go into the community, we go in our full PPE. This was one case that we had that needed sample collection of one who had died in the community, and those are areas that we go through. So in terms of PPE control, PPE use, we have some, but it is not adequate, and that's why we moved on to constructing that booth that really helps a lot in terms of even use of PPE. It minimizes transmission of COVID, and also ensures that the health worker is safe and is comfortable mentally and physically. Other things that we have done and put in place in terms of mental health is group debriefs. because we divided our staff into 3 shifts. One shift comes in for a whole week. Since our workload has reduced almost to 30%, we come in once a week, and during that reporting day on Monday, we do group debriefs with the team that's exiting and the team that's coming in. And we talk about the issues that we have encountered during the week, engage and share knowledge, and then the team that's leaving for the week leaves and the new team comes in knowing what they may encounter or the challenges that they may encounter at work. Community engagement is key in anything you do, because if you don't engage the community, they won't change their practices and they would not accept our health workers. Where I work, it's a region where, yes, education is still not very high, at a very high level, but engaging with the community has really helped, because now they do understand what COVID is. They do appreciate the health workers that are working with them. And since we do not have a special team for COVID and everyone is working in the COVID areas, we do not have so much of stigma that the community would reject someone. We've heard of areas where stigma has happened within the country, and we are trying to encourage them to embrace the system of everyone doing the same thing, so that there is no special group and there is no segregation. Thank you.
Wow, Dr. Joy, thank you so much for such a practical and also visual, you know, to give us a visual of how things are going. I think there's so many lessons to be learned. So thank you so much for sharing that with us. Really, really valuable. I think what I'll do is just as we're, as always, kind of short on time, we're answering as many questions as we can in the chats and in the Q&A, but maybe just to come back to each of the speakers and just to ask you, maybe I'll come back to yourself, Will, if I can, just to kind of leave us with some, you know, what would be your top 2 pieces of advice or recommendations, or something you want to leave us with in relation to occupational health and protecting healthcare workers?
So my 2 pieces of advice would be, firstly, about the tiered controls. And I think Joy demonstrated that brilliantly as to, you know, how that's been done in Kenya. And not just rely on PPE, because it doesn't always work. And my second thing is to look after your people and to provide them with lots of support and really to reach out. And it's not only the duty of managers, but it's everyone working in healthcare to provide peer support. And I heard a great thing from Professor Neil Greenberg, and what he said was that resilience doesn't come from the individual, but resilience exists between the members of the team. And it's the team working together that breeds that, that strength.
Great, really clear. Thank you so much. Professor Coco, just coming to you, again, just leave us with two things that you would like us to leave us with as we move on from today. I'll just have to unmute you. You have to unmute yourself there, Professor Coco. Yes, you're good.
I'll say, yeah, education and preparedness. These are the keys, in my view, for workers to be able to deal with such events that are not really at the end unexpected. Something like that will happen again, and this time we need to be ready. And all healthcare workers should be aware that they have to deal with sick people, and they need to be prepared to do that. They need to be conscious of that when they start working in the healthcare field. And of course, they need to be able and to be protected before knowing that a patient is not affected by a transmissible disease, not after that. You know, we say that it's like, you know, shutting the barns when the cows have already escaped.
Thank you. Very powerful, a powerful image. Thank you, Professor Coco. And coming back to you, Dr. Joy, just give us again two pieces of advice from Kenya. And you've already given us some great wisdom. What would you leave us with today?
Thank you very much, Nadine. I would leave the health workers with this. Assess your risk. And once you have assessed your risk, stay safe and ask for help. Thank you.
Very clear. Thank you, Dr. Joy. And just kind of in the theme of continuing practicalities, we wanted to show a very short clip of a video that's been launched this week for preparedness in Malawi, in fact, through a partnership between an institution here in Ireland and an institution in Malawi. So Hala, if you could take that over and show that to us. Thank you.
So we started this video series, and it's about 14 video series, short animated videos, and the aim is actually to help and assist health workers in low research settings to prepare for COVID-19. So the topics are, for example, preparing your facility, clinical management, palliative care, PPEs, and protecting health workers. There are many partners involved in this, which is Gori Malawi Partnerships and Partnership, Esther Ireland, HSC Global Health, and also Irish College of General Practitioners, the Global Health Group. And they are available on Facebook page and also in the website and our YouTube channel, Irish Global Health Network. So now we will just play one of the videos as an example.
Preparing your institution for COVID-19.
Hello, we can't see the video.
Part 1 of 3.
Yeah,
COVID-19 patient flow.
Ellen, the video, please.
Target audience. Healthcare managers and senior clinical staff in low and middle income countries. The aim of this video is to help managers of healthcare institutions prepare their institution for the arrival and escalation of a COVID-19 epidemic. This short video focuses on how health facilities should prepare for the spread of COVID-19 coronavirus in sub-Saharan Africa. It emphasizes WHO recommendations and is based on a document by Dr. David Wickham, Director of Ireland's Health Service Executive Global Health Programme. Implementing a health service response to COVID-19 is part of a wider national, local, and population-based response to control the epidemic. Population measures are of utmost importance, but are not the focus of this video. There are 3 priority objectives: to manage flow of COVID-19 patients, to protect the welfare of your healthcare workers, and to maintain essential health services. Your plan must be communicated clearly to all staff and patients and backed up by visible posters and signs. Consider the physical structure of your building. You will need to provide hand washing facilities in multiple locations for staff and ideally for patients. All patients attending the hospital, even those attending for routine appointments or following injury, should enter through a single entry point. At entry, all patients should be questioned and
Thank you. So yeah, this is an example of one of the videos. This is the first video, and until now, by the end of the day, we will have around 7 videos available. So please check them and share them with all your partners that you think they will need. And I guess by this, we'll finish. Nadine, do you want to say anything? Okay, so thank you really for this great panel, and also thank you for the Society of Occupational Medicine. It was our really pleasure to co-organize this webinar with them, and thank you for the amazing speakers for all those amazing inputs. And our coming webinar will be about sorry, I forgot the name. So it will be about the broader health and health systems impact of COVID-19 in lower middle income countries. And the webinar, this webinar will be available later in our YouTube channel. And thank you, everyone. We are running, I guess, already late. So thank you,
everybody.
Thank
you, everybody. Have a good weekend. Thank you.
Bye.
Bye-bye. Stay safe.